Hello everyone, I'm Torsha. I prepared this presentation to give a brief introduction about my research topic, including the background and the motivation for this research work. Cancer burden is still on rise. In the year of 2018, total number of new cancer cases were more than 18 million and the cancer death was 9 million. And every year this number is increasing. Tumor tissue consists of cancer cells, fibroblasts, and different immune cells. These cells continuously cross-talking each other and produce a favorable condition for cancer to grow, such as drug resistance, immune evasion, etc. So far, many anti-cancer therapy has been developed to treat cancer. Among those, immune therapy is the most promising to prevent or eradicate cancer. So far, more than 90 immune therapeutics has been approved by FDA. Among all the immune therapy available, immune checkpoint blocking antibodies are the most successful to abate cancer. They usually bind to the T cell or the cancer cell to eliminate the cancer cell. So far, FDA approved immune checkpoint inhibiting antibodies are PD-1, PD-L1, and CTLA-4. Even though immune therapy is very effective against cancer, it also has limitations. Tumor-targeted delivery of antibody induces several major side effects in the other organ of body. These side effects are collectively known as immune-related adverse events or IRAE. About 90% of the patients receiving this immune therapy suffer from IRAE. Depending on the severity of the IRAE, it can be life-threatening as well. Incidence of IRAE results into patient incompliance, therapy compromise, therapy termination, etc., which can be fatal for the cancer patient. So far, several strategies have been taken to improve antibody efficacy and to reduce side effects, such as using fully humanized antibody instead of mouse or chimeric antibody to reduce species-related side effects, or using only the binding site of the antibody by fragmentation, or the multimerization of the antibody to reduce unspecific binding, or the conjugation with other active chemical to transport more therapeutic agent for improved activity. But these are limited by different factors such as lower half-life, lower tissue penetration, compromised efficacy, higher production cost, etc., which limits its application in a real scenario. Attaching PEG to the antibody considered as gold standard to reduce off-target binding of the antibody, but at the same time, attaching PEG can reduce the effectiveness of the antibody at the treatment site as well. So in order to shield the antibody from off-target binding and make it fully available for the therapeutic activity, the PEG should be released from the antibody at their targeted site. So here I have developed a novel PEGylated antibody with cleavable linker. At the physiological pH, PEG will protect the antibody from off-target binding, but at the lower pH, that is at the cancer site, the linker will cleave and antibody will be fully available to induce anti-cancer immune response. By this way, the immune-related adverse event will be minimized, where the 100% efficacy can be achieved. This is a very simple process which might be cost-effective and helpful for the real-life application of the antibody to treat cancer with reduced immune-related adverse event. Thank you for your attention. Please let me know if you have questions.